So let me start by saying that I'm very, very excited to be here. And as you can probably hear from my voice, and I would like to say thank you to Professor Panida for inviting me, and also to Professor Kanjana. Did I say it right? Good, Kanjana, for inviting me as well. Now, I will start my talk by asking you, the ones who are sitting next to me, what is the difference between a monologue and a dialogue? It's a question, please. Okay, so this one was the first test. The second one is to tell you that English is not my first tongue, and it's not your first tongue. And I'm very much aware of that. And you are mostly welcome to make mistakes in English, but please speak with me. I prefer dialogue over monologue. And believe me that I can give a monologue for not 1.5 hours, but for 5 hours. Ask my students, I can. Believe me, I can. So I will start my presentation. And if you have any questions in between, please do, okay? As for the ones who are on Zoom, I can't see the questions, so maybe somebody will tell me the question and I will try to answer. So first, let me introduce myself just a bit. I'm a senior lecturer. It's an equivalent for an associate professor. I'm not a nurse, unfortunately. I'm a social worker. I have my BA is in social work, graduated in gerontology and not social work, PhD in gerontology. And as you probably can guess, my public health postdoctoral position was on older adults. Older adults. I'm all about older adults. I'm trying to make my best within my research in order to improve quality of life of older adults as well as family members who are taking care of those older adults. Now, the first few slides are just general context in Israel and in Thailand as well. So at least in Israel, we are a relatively young society. About up to 13% of the entire population are older adults. In Israel, we identify older adults as 65 and above. It's a bit different than in Thailand. In Thailand, it's 60 and above. The meaning is that in Israel, we have about 1 point something million family caregivers, which is about 22% of the entire population. Now, I am aware of some of the differences between Israel and Thailand regarding caregiving and caregivers. However, I think that you will be welcome. I think that you will be surprised to see the similarities between us. To start, we are talking about an unpaid family-based care. Now, I bet that that it sounds familiar. The vast majority of long-term care in Israel is provided by family members and without any financial compensation. Now, as all the ones who are taking care of their older adults, multiple role demands appear. The meaning is that many of the caregivers combine caregiving responsibilities with employment and active parenting role. I will in a minute I will talk about the sandwich generation. In Israel, as in Thailand, gender disparities appear. And the meaning is that women provide significantly more caregiving hours than men. And they report about a higher burden of care. Sandwich generation is a phrase that means that middle-aged adults between 50 and 59 often take care of their parents as well as their older children or grandchildren. Now, when we talk about burden of care, we always talk about time commitment. If we are talking about statistics in Israel, so it will be about 1/4 of family caregivers who are spending 10 hours or more in caregiving. And that's only the direct care activities. When we talk about burden of care, and we will talk a lot about burden of care today, caregiving is associated with psychological strain. It is associated with work interference. The meaning is that they are going to lose hours in work or days in work, as well as comprise personal well-being across diverse Israeli population. And like in Thailand, the Israeli society is divided to many kinds of caregivers. So just a bit about family caregivers in Thailand. So as you can probably not see because it's too small, so please try. Older adults in Thailand is about 20%. It's like it's twice as in Israel. And this is actually the main reason why Thai society is classified as age society. Age society, and as predictions, and I saw the projection just last night, it will eventually come up to 30%, and it will not take much. Like between 10 to 20 years, you will be at 30%. As in Israel, in Thailand, it's all about family-based care. Family members provide overwhelming majority of the long-term care in Thailand as well, like in Israel. And like in Israel, we have service gaps. And the meaning is that formal long-term care services remain limited, and especially on rural side areas, meaning that most of the older adults will get informal caregiving. Now, in Thailand, you have, and we have in Israel, some cultural foundation related with caregiving, and it is viewed as fundamental moral and familial responsibility rooted deeply on the Thai side in the Buddhist principles and in the Israeli side on the Jewish principles. In Thailand, like in Israel, 60% of all the family caregivers, 60% of all the family caregivers are female and not male, and the average year of age is 55. Just a quick roadmap to my lecture. First, we will talk about caregiving burden foundation. What is caregiving? Then I will go over the quantitative and qualitative studies. Both of them were done by me and my two friends that once upon a time were my professors. So after I graduated, they called upon me and asked me if I would like to join them. And on the fourth and fifth parts, we will discuss my research challenges that were ethical and methodological, and we have very much of those. And at the end, just touches in practice implication for nursing. So as I told you before, my talk is a dialogue, and please feel free to ask me in the middle. So burden of care, and I know that you have courses about burden of care and you are talking about burden of care. However, burden of care should be at least identified here as in the room as something. And this something is cumulative, multidimensional strain experienced by individuals caring for family members with chronic illnesses, disability, frailty, and it is profoundly impacts emotional, physical, social, and financial well-being. Now, I tried to list all the things that might be inside this burden of care, and we mean emotional strain. Emotional strain might be related with worry, guilt, and grief. Altogether, in some cases, more worry, in some cases, more grief, but they will appear at a certain stage. Physical toll. Physical toll is highly important for social workers and for nurses, as we are the ones who are generally see both older adults and caregiver. And the meaning is it starts with fatigue. They look very, very tired and might report on health decline. And it might be a small decline, it might be a large decline, but they will tell you that they are going down with their health themselves. We are talking, this talk is about the caregivers and not the care recipients. Some of them will report about social isolation. Social isolation and loneliness are combined. And the meaning and the reason is that because of the large amount of hours that they are spending giving care to their older adults, they have limited personal time and they will lose their social connection. Some of them will tell you about financial stress, meaning that they have to be with their older adult, but they have to work and they have to decide which one is going to get higher hours of attention. Is it work or my father or my mother or my grandmother? It's not a simple choice. We know that burden of care is linked to adverse health outcomes. And those health outcomes are depression, anxiety, compromised immune function, and even increased mortality risk. And still, we know it all. We know it in Thailand and we know it in Israel. However, burden of care still remains under-identified in family-centered culture like ours. And why? Because culturally, it might be perceived as familial duty rather than potential health risks. Now, I'm not claiming that we should not take care of our older adults. I'm claiming that we have to do it wisely. I picked two examples from my research which are very special for me. One is because I did it with my two professors. After, of course, I came back from the United States for my postdoc fellowship. One is an expert on qualitative and one is an expert on quantitative research. And believe me that the amount of stress that I was while working with them, my two professors, and I have to come up as somebody who knows what he's doing. The second thing is that ultra-Orthodox Jews, highly religious Jews, are a minority group. Just a minute, I saw you. Is a minority group in Israel, but they have very, very specific characteristics, and we will talk about it. Yes, you wanted to ask something.
Yeah, excuse me. Sorry to interrupt you. So I have a question. When I read your slide, I saw this slide focus about the religion. So why you interested about to link the religion to caregiver burden? It's like you talk about Jewish culture and Buddhist culture. So is there to influence the responsibility of the family caregiver? why you have this idea of that? I'm curious about this question.
Yeah, because first it's an excellent question. I will ask you, do you know what is an excellent question?
No.
No. Okay, so I will tell you what is an excellent question is a question that the lecturer has an answer for it. That's an excellent question. Now, it is an excellent question. I'm talking about burden of care because it will appear in any caregiving situation. It doesn't matter if it's Buddhist, Jewish, Christian, or Muslim, or any other religious part. And it will appear in societies which are less religious. And in order to give them the proper care, we as professionals, we have to understand the basics of this burden of care. Otherwise, we will not be able to help them help their older adults, family members. So we really have to understand what is the nature of this burden of care, what are the sources, and eventually how we can help them. That's our main, as nurses, as social workers, as physicians. We are here to help them. And this is why I'm investigating burden of care. And this is why I'm trying to drill in minorities and to look for similarities or differences between societies. But I will tell you that at the beginning, the burden of care has similar characteristics all over. And you will see it pretty soon.
Okay, thank you.
Okay?
Yeah, thank
Good.
you.
So just to present the ultra-Orthodox society caregiver, you have to go, Panida? Okay, cap. So it's first we will start with religious identity. They are highly religious and they are minority in Israel, and they have distinct cultural practices and strong adherence to traditional Jewish law, which actually influence the entire aspects of daily living. The second thing is that they have filial responsibility. By filial responsibility, we aim to responsibility that we as family have regarding our older adults. Now, in the ultra-Orthodox society, and I'm not ultra-Orthodox, I'm secular, and I still have this filial responsibility. On this society, it's much, much stronger. It's all about family-based caregiving, religious and moral obligation, and you will see it especially on the qualitative research that we did. The last thing is the service utilization. Older adults and caregivers in the ultra-Orthodox society in Israel have limited engagement in formal health care and social services. They prefer to take care of their family by their own and not to be supported by the government or any other services outside of this society. Now, as for the cultural relevance, it will come very clear pretty soon, okay? So the first published paper is a quantitative one. It's a cross-sectional one. It's an investigation about the burden of care among the ultra-Orthodox family, especially about the relatives. And we tried to employ validated instrument of burden alongside other psychological well-being and social support factors. Now, I know that you are research students. Some of them are on graduate level and some of them are on PhD level. And it even makes me happy because I will try to test you just a bit, just a bit. So the sample size is 107 caregivers, and it's in community bewailing framework. sample size and sample characteristics, we are talking about a mean age of almost 60. And I bet it sounds familiar in Thailand because that's the same age in Thailand. I told you that about 60% in Thailand, the women are female caregivers. It's the same here. Adult children or spouses who are taking care of their older adults, it's the same as in Thailand, and that's the proportion. In most cases in Thailand, you have less than 6 children per family. In most parts of the Israeli society, we don't have 6 children per family. We have about 2.5 kids per family. But ultra-Orthodox have more children. The amount of caregiving, it's about 3 years, a lot of time, 7 days daily. If I was to tell you that you are going to treat your parents, maybe your grandparents, 3 years, and you will do it 7 hours a day. Sounds like much, sounds like not so much, sounds like a challenge, not a challenge. What is it for you? Challenge or not? Is it going to interrupt your life or not? I bet it will interrupt, and it's a challenge. It's a huge challenge. Now, for the ones who are doing thesis or maybe a PhD and are interested in quantitative measurement of caregiver burden, I hope that you heard about the Zarit Burden Interview, ZBI. ZBI, you have it in Thai as well, and it is the most common measure for burden of care. We added the mental health. It's the hospital anxiety and depression scale. And the question is, why hospital anxiety and depression scale if you're talking about derailing older adults? The answer is that you can use this tool safely in other environment than hospital. The last one is self-rated health, coming from the World Health Organization. We added the social support and functional, physical functioning, meaning dependency level. And it's about numbers, and I'm not sure that you can see it in a good way. I will try to help. No, I made it worse now. Okay. So if to read it from the table without the text, what can we say about the burden of care in this study? The range is 0 to 48, and the mean is 20. Is it high? Is it low? Is it moderate? What is it? It's not a very complicated question. Please go along with me. Very moderate. Just in the middle. So just a minute ago, I told you that they are spending 36 months and giving 7 hours a day and still reporting moderate. That's interesting, very interesting. Now, if to look at the social support, If to look at the social support, what can we say about that? Social support, here it is. Okay, so the range is 1 to 7, and the median and the mean is what? Is about almost 5. Here it is. I'm pointing it. Almost 5. What is the meaning of that? One is very small social support. 7 is very high social support. What would you say about this one? Very high. Very high. It's above. It's above the middle of the scale. It's not 3.5. It went up to 5. It's very high. So it might be later on with the regression analysis, maybe an indicator for something. Mental health, anxiety, and depression. What can we say about that? So the scale of the depression and anxiety are going from 0 to 21. 21 is high depression and high anxiety. And we have a mean of 9 point something and 7 point something. Depressed, not depressed, just in the middle. Between 0 to 21, they have 9 or 7, depends on the instrument. I would say that they are reporting a relatively high level of anxiety and a bit less on the depression. Okay? Now, please have a look at the way that, no, this one. Next slide. Oops, next slide. So this one is the, oh, just a minute. Okay. This one is the regression that we made with hierarchy, multivariate regression analysis. And I bet that you have seen multivariate regression analysis before in the past. And you can see that it is divided by caregiver characteristics, care recipient characteristics, and situational characteristics. When we take a look at a chart like that, we always ask ourselves why. Why did these researchers splitted the regression to 3 parts? Do you have an assumption why did we split it by caregiver characteristics, care recipient characteristics, and situational characteristics? What is the reason for doing that? There is a reason, a good one. Try your best. Worst cases, you are wrong. It's okay to be wrong.
Would you mind to repeat the question again?
Yes. When we just please have a look at the chart, okay? Do you see that we have it on caregiver characteristics? The second block is care recipient, and the last one is situational characteristic. Why did we choose this kind of analysis? Why? What is the reason? There is a reason. We could take all the variables together and do it in one block. Why?
From my understanding, I think the caregiver and the care recipient relationship might shape the way they look at the caregiver burdens, and also it influence the mental health and physical health as well. So, for example, if the caregiver was adult child or spouses, so they have difference in terms of emotional attachment, and they might invest the time different as well. So most of these might shape the way they look at the caregiver burdens and also the level of the caregiver burden as well.
Okay, that's a good answer, but I would like to add just a bit. The main reason is the theoretical framework that we used. And you are not totally wrong. You are not. Because the way that the this theoretical framework works is actually saying what you were saying, but in different words. Check, each part dividedly, not together. You have to understand which one will contribute more to your understanding about burden of care. And this is why it is done by steps. Now, do you see the number 0.483? on the left side, R square. R square meaning that the percentage of explanation of the variance. The meaning is that the first part contributed 48.3% of the explanation of the variance, which is pretty high. And I'm reminding you that we are talking about caregiver characteristics. Now, if we are talking on the second part, we can see that it went up to 0.49. The meaning is that this part added only 1%. That's it. Care recipient characteristic, meaning in this theoretical framework, physical functioning, meaning dependency, added only 1%. And when we added the last one, the situational characteristics, which are caregiving hours and social support, caregiving hours were not significant. What was significant is the social support. Just like 10 minutes ago, we talked about the social support, and altogether we claimed that it was high, and it is high. The main thing, do you want to ask something? Okay.
Thank you. I just have some question about it. If we use like the all enter for the all factor and by step by, so for the last for the third third
I will make it
the last one
just a minute.
It's like a very answer our question from the framework.
Here it is.
Yeah.
Okay, so what do you mean? It added about, here it added about 4 point something percent. That's it.
Yeah. For these three steps, you use the all enter or the step, right?
Stepwise. It's an excellent question. Stepwise. Yes, you take it step by step according to your theoretical framework, which means that first you check by this theoretical framework, you check the caregiver characteristics, then the care recipients, and then lastly, the situational. And true, if you wanted to check mediation or moderation, it's not the way to do it. Well, it might give you some indication about mediation, but not more than indication. If you would like to go for mediation or moderation, you should do structural equation modeling, which might be excellent. But the sample size here is only 107, which is very low for structural equation modeling. However, it is sufficient to do multivariate regression. It's okay. Now, this research actually challenges one assumption, and as it's already, I told you that it explains about 55% of the variance with psychological and health factors who are dominating over the care recipients' characteristics. It has a meaning. Not going? Just a minute. Oh, stuck. Yeah, it's stuck. No. Oh, just a minute. Okay. Okay. And for the meaning, okay. And for the meaning, the practical implication for nurses as well as for social workers, we should understand that we, the ones who are giving the treatment are playing a key role in helping those caregivers. And there is a clear gap between patient's health and stress that they might feel. You saw in the regression analysis that physical functioning was not a significant predictor of the burden of care. It means that it's not just about how sick or how healthy the care recipient is, but what is the feeling of the caregiver. That's the meaning. And we have to recognize this gap first, and we have to assess this mind gap. And assessing the mind gap might be with validated tools. Validated tools should be used in order to understand if our caregiver is under huge stress, exhibits a burden of care, might be under severe anxiety because he or she doesn't know how to take care of the care recipients, or might be under depression. Now, depression in Israel and in Thailand might be with different symptoms, but we have to at least understand that. According to this study, we have to prioritize mental health. We have to assess and to address anxiety and coping over anything else. We have to check if the caregiver can function as a caregiver, and if not, to try to help her or him. And it means regular checks in. It means that when they come to see us, it is not just about checking the older adults and giving him treatment, but to assess the caregivers as well. If they are not, they are the ones who are going to be with the care recipients the most time. Not a physician, not a nurse, not a social worker. Them. If they are not going to function in a good manner because they are not fit, they are under anxiety, depression, or whatever, the care recipient will not get the treatment that he deserves or she deserves. Questions?
Yeah. It's quite a very interesting thing because your population that you focus, the caregiver age is maybe like a spouse and their son or daughter. So I think maybe for the near future, I think the spouse is maybe getting old because the average age right now is the 59 years old. After that, I think the physical function is maybe
going up.
Yeah, going up and maybe have some problem. I think that issue is quite very important for our nursing staff to be planned for our next step to care for both for the patient and also the caregiver burden. I think it's quite a big issue right now. What do you think about that point from your study?
First, you're totally right, and it is a huge issue here and everywhere. Here in Thailand and everywhere. And why? Because the entire global population is going older. And the meaning is that for sure the caregivers will go older. And in order to be prepared for that, we have to do something. And this something, if we know about the paradigm of aging in place, and aging in place means that we should keep our older adults in the community, somebody will have to give them care, and this somebody is us. I'm giving care to my parents. I'm 51 and I'm the primary caregiver. I'm in Thailand and still I'm the primary caregiver. You see by my voice that I'm a bit excited now because just maybe 10 seconds before I entered this room, my mother called me that my father is not feeling well and I'm the oldest son. Okay, so take the call now and do something about it, right? I will do something about it once I will finish the presentation, but not now. This is exactly when research and real life combines. And this is my opinion. the entire world governments have to pay attention to this particular group in the population. In Israel, only 5 years ago, suddenly there was a website called Caregivers. You can check it, caregivers.org. It's in Hebrew and English. You can go online and check it. I didn't tell you that, but I'm part of the National Special Task Force for evaluating all the health and welfare services for family caregivers, not for the older adults, for the family caregivers. Only now, we are working on that for at least almost 2 years, digging and trying to understand if they're doing good or not good, trying maybe provide good care or not such a good care. And it takes time and we get resistance because nobody wants a professor from the university coming to check him. No, they don't want us. I'm using an algorithm, I'm not asking them. I trust the algorithm. Okay. As for now, do we have any questions? Maybe questions from home, from the Zoom? No. Just a minute. No?
Ofer, I have something to ask.
Yeah,
I am Ganjana. Yeah.
Hi, Ganjana.
Yeah, it's a nice presentation. And so I have something because for this is a quantitative research, right?
Yeah.
And so something like when we ask, it is a self-assessment.
Okay.
Sometimes it seems like if you take like the time that they take care for family members, it should be like a 6 hour. It seems like a full-time work.
Yeah.
So if they are children, it means that they have to work or something. I mean, I want to ask, normally the ladies in Orthodox or in Israel, do they work a full-time concurrently with the housework?
Normally, yes. They work full-time or part-time. Most of them are working.
Yeah, and so when they work and then they spend some time with their family, would it be possible with the religions that they cannot say that this is a burden, but their responsibility that they have to take care for their family?
That's correct, and this is exactly why I brought in my second study, when they don't talk numbers, but they talk with their own words. And you will see it in like 2 minutes. This is exactly the situation. And this is exactly the difference between qualitative and quantitative research. Now, quantitative research, the one that we already discussed, it's about numbers. We measure something, and we can decide by ourselves if it's high or low burden, high or low anxiety, depression, social support, or whatever variable that we picked. We do not hear their voices. We don't. If we would like to do that, we pick the qualitative side of research and we go on qualitative research and not quantitative research. Now, very few of my friends go with mixed methods research, meaning qualitative and quantitative combined. And it should, and if to tell you that in a very straightforward way, very few researchers are pure mixed methods researchers. It's not just to take qualitative, quantitative, combine them, and Good, you have a mixed method research. No. They are specialists on mixed method, and the two papers that I'm presenting were not mixed method. Those are made separately, because we are not expert in mixed method. One of my friends is an expert on qualitative, the other one is qualitative, and I'm in the middle, doing the job.
It's okay. And so one question is that I want to ask your opinion. Would it be possible if sometime we use the instrument that developed with the Western culture, and then we use the translation, even we use the term cross-cultural translation? It should be the point that when we use self-administering tool by translation, they have some conflicts or something like it's not deeply understand for our own language.
Yeah. So I got your answer, and a good answer for that would be that first, for quantitative research, always try, at least always use already validated and translated measures. That's for the quantitative, meaning that the Zarit Burden Inventory, ZBI, was already translated to 1,000 languages and validated. So use it. Or the World Health Organization for Self-Rated Health was translated and validated. Use it. Otherwise, when you publish, you will get attacked for not valid. It's not asked to sit in the office and translate it like that and that. No, validation and is a long process to do, and involves a lot of statistics. Welcome, a lot of statistics. It's not for thesis. It might be for doctoral. Yes. For doctoral, yes. And the second part of your question, as for the qualitative side, you can easily take all the questions, and if you would like that, I'm more than willing to share it with you. All the questions related with burden of care, as was asked to the ultra-Orthodox caregivers, you can translate it very carefully, and to maintain cultural appropriateness, because it might be that in Thai culture it's not applicable to ask in this way, but I should ask that way, which is culturally sensitive. And you can do it easily. And those are the pros and cons of picking qualitative or quantitative research. Now, I'm not sure that you are doing qualitative. In Israel, at least for graduate master thesis, in some cases they do qualitative research. In most cases, they will do quantitative research. In most cases, quantitative research will not involve mediation moderation. For PhD, of course it will. Otherwise, that's the next step in entering the academia. They should do moderation and mediation terms. Okay. Did I manage to answer your question?
Okay, it's all.
Yeah?
Thank you.
Okay. So what is the time? Ooh. Good. Okay. So the next one is qualitative. Qualitative, which allowed us to go beyond numbers. Allowed us to capture nuance in the way that caregivers explain their experience, but especially with cultural and religious lens, and actually unveiling the way that they feel burden and other things, and the way that they manage that. You can never see it in quantitative research, only in qualitative. So we tried our best, and it took us a lot of time to get 28 care givers. And as those are religious caregiver, we should use gender matching in order to interview them. The meaning is that if the caregiver is a female, I should send a female interviewer. Otherwise, she will not speak with me. Same goes for men. If it is a man, the interviewer should be a man. It's not the same as going for self-reported questionnaires that I can send them by the phone, by the email, whatever. No, here is a face-to-face interview. And if it's not on gender matching, it will never happen. They will not talk to me. By cultural embodiness, we mean that we had to recruit interviewer coming from the ultra-Orthodox society. I'm secular. They are ultra-Orthodox, very religious. Again, they will not give me the information that they will give somebody within the society. And of course, that we had to be very rigorous with the analysis going on breeding. Now, it's not a class on statistics and research methods, but just to check if you know what is breeding on qualitative. Do you have any idea? Any idea about it? Two main ways in order to be rigorous with your analysis in qualitative research. The one is breeding, the other one is bracketing. Bracketing meaning that you open brackets after each sentence, each answer, each communication. And breeding means that you have a diary and you explain to yourself what might be points that you, as a secular researcher, be maybe against things that they told you, or maybe very much like things that they told you. You have to understand yourself before going to the analysis. It's very complicated to do, and you have to be very, very honest while doing so. First, because somebody invested a lot of time in answering your question, answering your interviewer question, not myself. And second, you're going to publish it. And in order to maintain ethical attitudes, you have to be very, very honest about yourself. You are going to interpret all the outcomes, and you have to do it in a very, very robust way. Okay, so when we are talking about the qualitative, we had 3 teams, core teams. The first one is universal burden, which means that burden, and it doesn't matter if it's ultra-Orthodox, secular, Jews, Buddhists, Muslims, Christian, has a universal characteristic, and we will see that. The other one is spiritual meaning. The Buddhist society, as well as the ultra-Orthodox society, works within faith-based frameworks. providing spiritual meaning to caregiving work, and you will see it in a minute. And the last one was service expectation, and they reported on modest, very modest expectation from formal health and social services. The first one is burden as a universal experience, and they did, oops, what is going on? Okay, and they did report about emotional overload, and they mentioned worry, grief, and emotional exhaustion. They were overwhelmed with the emotional demands of witnessing their loved ones going with a decline situation, and still had to maintain a very, very strict posture, composure, to show optimism regarding the situation of the family member. Second is the work overload. And this one means that, like every sandwich generation, it's not just about their parents. They have children and they have grandchildren, and as you saw, many of those, 6 children and probably an average of maybe 20, 21, 25 grandchildren. And they have to accommodate the role overload. The last one is hidden fatigue. So I started my conversation, my lecture, my talk with mentioning the fatigue. It appeared as well here. And, you know, despite all the expression, the public expression of devotion and meaning and a willingness to take care, many of them privately and not openly discussed profound physical and mental fatigue. So on the outside, they might say, yes, of course, it's my obligation, and I do it with a great devotion and willingness to take care of my parents. And they will not tell you that they are super fatigued. Not publicly. Privately, maybe yes. And by the way, even not that privately, they will not say it to me because I'm secular. They will say it to somebody who is within the ultra-Orthodox society. Yes. The other one is faith-based meaning. And the meaning of that is that religious and spiritual leans are directing the entire experience. So first, we have a framework called a mitzvah. Mitzvah, the translation of mitzvah is good deed. Good deed that you are doing for somebody, especially for your parents. And at the end of my presentation, I will show you the parallels in the Buddhist phrases as well. It's a religious commitment, a moral duty that carries divine significance. It's by God. Spiritual reward, meaning that there is a spiritual merit that occurs through this painful process of caregiving, and it is painful. And the last one in this one is the burden transformed. And we mean by that there is like a reframing of burden as an honor, as a sacred obligation, suffering and meaning of spiritual work. The last one is expectation from services. In ultra-Orthodox society, in religious societies, family is first. And the meaning is that the primary reliance will be on family member. And if not from the inner circle, from the extended circle. This is preferred and expected, not just preferred, it is expected by others. It is not, just imagine somebody within this society that directing the caregiving to rely on family. And somebody decides, no, I will not take care of my family, my parents. I will bring somebody else. Maybe I will buy service for that. I will pay for that. In a very strict religious society, no. No, it will be a huge stigma on him. You are laughing because it resonates in your mind. It will never happen here as well. And this is why I picked those papers. Community networks. Ultra-Orthodox caregivers usually have secondary support from the community organizations. Myself, as a secular individual, I don't have the same community networks as they have. And they can rely on those community networks. The third sub-theme is minimal formal expectation. They expect very little from the health services. They perceive them as incapable. They don't understand the culture. That's the perception of the caregivers. And they are insensitive to those. Now, just only 10 years ago, about 10 years ago, in the major hospitals in Israel, they started a special service for the ultra-Orthodox, meaning that they are very, very sensitive culturally and religiously to things that you might do, offer, and the ways to offer treatment to ultra-Orthodox Jews. It's not the same as offering treatment to me or checking me or even speaking with me. Not the same manner at all. The last one is unspoken needs. Unmet needs often remained unvoiced. Caregivers, at least in our experience, were reluctant to articulate the struggles or to request help from outsiders. They don't want to talk with us more than needed. They will say something, and this something are the unspoken needs. So I'm reaching to, I have some more time, but I'm reaching to the end of this talk. And we have to discuss some research and ethical challenges, and please feel free to ask me whatever is needed. Community access. Both studies were done by using interviewers within the ultra-Orthodox society. The meaning is that we had to gain access to the community. We had to build trust with the community. We had to approach religious leaders in order to get their approval to approach the communities. And actually, we used insiders in order to vouch the message that we are okay, we are not against. We try to help them. We try to develop services. We care for their older adults, and we are not investigating them as governmental decision to chase them for something. No, it took us a lot of time. 28 participants took us about a year, 1 year. 107 participants in the first one took us like maybe 5 months. It's totally different from face-to-face interview, one-to-one, or just send them the questionnaires. Not the same. And still, they were very, very suspicious. Very suspicious. We tried, when we talked with them, we tried to avoid harm. And the meaning is that when you are discussing something about the ways that you give, that they give care to their older adults, you cannot compromise their beliefs. You cannot compromise their ways. You should be very, very gentle and avoid any psychological harm by maybe planting an idea that they are not doing good and might jeopardize their own older adults. Last one was gender and modesty. Gender and modesty. Now, I went online online for the Faculty of Nursing here, and you have a section for modesty. Did you know that? Online. Modesty. Modesty is super important. Super important. If we, as researchers, would act in a way that is not modest, which is not gender matched by sending a man to interview a woman or vice versa, and not in a modest way, it would be a huge problem. First, it's not a nice thing to do. We are not giving them honor in this way. And second, they will not talk with you. They will terminate the interview immediately. Immediately. Two, three last slides. So the implication for nursing. First, challenge the assumptions. Challenge the assumptions. Do not assume that low burden due to cultural expression of devotion and or religious framing of duty means that they don't have burden. Second is the proactive assessment. We should proactively assess caregivers for self-reported distress. We have to implement a routine of screening to check them when they are coming with their older adults. That's the most frequent case. We see them when they come with their older adult. I was working as a social worker in the internal division in a primary hospital in Israel, internal and neurosurgery, and later on services outside of the hospital. Usually they come when they have an issue. They don't come just to talk with us. And that's the immediate point when we can assess if they are under extreme burden or not, and if yes, to try to do something about it. The last one are the cultural expression. We have to recognize culturally shaped expression of distress. They might not tell us that they are distressed. They might not tell us that they are burdened. They might tell us something else, and we have to very gently check the nature of this report. So I promised some parallels between the Thai and the Jewish-Israeli context. And it's really about the filial obligation, strong cultural expectation for filial duty and respect for the elders. In Thai, it's Krang Jai and Bun Kun. And we have similar phrases. And it doesn't matter if I'm Jewish, Buddhist, Muslim, or Christian. We have phrases of the same. As health professionals, we are ought to do it, and we are ought to know it. Okay, I did it. Last one, because I would like to leave some room for additional questions. As closing reflection, how can nurses provide meaningful support to family caregivers without challenging or undermining the cultural or religious values that gives a meaning to their caregiving work? And the other one is culturally appropriate assessment. We have to be very, very careful in the way that we assess. What assessment strategies are culturally appropriate and acceptable in the specific practice, in the specific setting? It might be in the community, it might be in hospitals, it might be elsewhere. How can you identify caregiver burden when direct verbal disclosure may not be appropriate? That was my last slide. You can scan the QR code. That's my Google Scholar page. I will send, if you want, the presentation itself, and my email is over there. And just to say, cup on cup. So I'm open to more questions if you have any.
Actually, I have 2 questions. First question is I'm curious about in your qualitative relation, the research part. When I noticed that the characteristic of the participant, most of them is females and the adult children to take care of their parents. So as I know, it has a big difference. The responsibility is the big difference from the caregiver. Like if it is from the spouse, they will spend more time to take care of their husband or wife, and the adult children maybe less time. And if for the patient is children, maybe their parents spend more time to take care of the children.
Yeah.
So how can you recruitment or enroll the participant in your research to decrease the selection bias in this research? That's my question. Yeah.
So first, this one is a cross-sectional.
Yeah.
Yeah. Well, we are not perfect. And second, it's on convenience sample. It's not representative in any way.
Okay.
Now,
Yeah.
the best way to deal with your question, and it is a good question, is to go for representative sampling, which might take 1,000 years. In my case, it will never happen. We don't have, in Israel at least, we don't have a way to go for let's say, randomized or maybe stratified or maybe clustered, whatever. We don't have a way to do it within the ultra-Orthodox society. If to take the entire Israeli population, I can do that. As long as I can identify somebody as an ultra-Orthodox. It's not that the Internal Affairs Ministry knows if I'm ultra-Orthodox or secular. No. It's very, very complicated. It's a good question. We tried at least to sample some of these, some of those in order to represent in a good manner. However, to be very strict, no, it is a convenience sample.
Okay.
It is a convenience sample.
Yeah, I can understand.
Yeah.
Yeah. It's really the society situation.
Yeah.
Yeah. And the second question I'm curious about, because the Israel is a very flourishing the society, especially in the economical, the insurance. Why I saw from your slide they mentioned about the financial burden. Yeah, because in our Asia country, especially in China, we facing this kind of problem. But in the Western country, you have enough the financial support and the insurance support.
You see why I'm laughing?
Okay. Yeah. That's
okay.
my
I will give you.
yeah.
I will give you a very, very short and nice example. Okay. How much is it for pad thai in Thailand? How much? 30 baht is cheap. And if you want the fancy one, it will be 70 baht. I eat pad thai all the time. 2 months, I eat pad thai. I know the prices. 70 bahts. In Israel, pad thai will come up to 700 bahts. Did you get the message? That's the message. True, Israel is flourishing.
Yeah.
True. It's a nice country. It's a good country. It's a super expensive country. Super duper expensive country. Probably the most expensive country in Europe and the Middle East. Okay? So in order to have private service for my father, I will, and I'm talking about 5 hours a day, okay?
Yeah.
The other 5 hours might be provided by the government. Might be. Why might? Because if my dad has a pension, and he does, he might not be eligible for the assistance from the government because he has enough money and he can buy the entire 10 hours that he needs.
Yeah.
So we are talking about sums of money which are in Thai bahts. 170,000 bahts. 170,000 bahts to have somebody with my dad for 10 hours a day. Now, if it's only 5 hours, you can divide it by 2. So it's only 80,000 only, because the government will pay the rest of it. My dad will not get it because he has a pension, not eligible. So in Israel, the financial burden is one of the most reported burdens when talking about care burden. In some cases, I'm not that familiar with the situation in Thailand regarding medication. However, in Israel, there is the medications are subsidized to a certain level And from that point, you will pay it by yourself. And some of the medications are not subsidized at all. And it costs a lot of money. Actually, the most it's not good, but it's a good comparison to the health system and welfare system is for the American one, which is very, very expensive.
Okay, thank you for your
Thank you for your patai example. Okay. Yeah.
I have a questions about the qualitative study.
Yeah.
Okay, of the participants, is like the part from the quantitatives or you separate?
No, totally separated. Not the same individuals.
Many participants you got the data situation?
On the qualitative?
Yes.
28. 28 complete questionnaires, interviews. But as far as I can recall, it was about 40 something not completed, meaning that we lost about 12 or something participants because they didn't want to continue with.
Do you have any criteria to include them?
Yes, the inclusion criteria were to be part of the ultra-Orthodox community. That's the first one. The second one is to be a caregiver of the primary caregiver of the older adult. The third one is to speak a fluent Hebrew because it's in Hebrew. Some of them do not speak fluent Hebrew, but Yiddish is like German of the Jewish people. They speak Yiddish and not Hebrew. I can't speak Yiddish. I don't know Yiddish. And those were the major inclusion criteria for those. On the other one, and of course above the age of 18. Otherwise, they are minor and we cannot interview them. Okay.
Okay, I have.
Which one?
What do you think about the further study that should be done? Because in Thailand right now, especially my PhD student, he interested in the burden for the caregiver. However, in Thailand, we done a lot of the project like capacity building for the caregiver, both in the family caregiver and also the community caregiver. That will be supported by our government. So, but right now. I got your message from the qualitative, like the proactive assessment. But in our community, sometimes when we collect the data and assess, we found that the burden is quite a low score.
Because they don't report about it.
And however, after that, when we follow up, we found that they have the suicide idea.
Suicidal ideation.
And suicide ideation. So after that, we have to try to
monitor
prevention, to take care of the caregiver. So right now, I just we start for the review for the literature. So we would like to know for the further study and how should we done for the something. Okay, thank you.
It's first. I started with saying that burden of care is highly correlated with depression, anxiety, and it's not a huge surprise that you are talking about suicidal ideation, which is right. You talked about suicide.
But during we assess for the burden, we found that it's a low score. But by the way, when we assess for the mental health problem, some of them very high score. But who have the suicidal attempt
Okay.
He
Didn't say anything about
Yeah.
burden of care.
and
So this is
mental health
exactly what
problem.
I'm saying for at least 90 minutes here now. In some cases, if it's not culturally accepted, they might not tell you that they are under burden of care because it's not culturally accepted. So they will not tell you that. What should be done? First, check the way that you are assessing burden of care. You might be using a tool that is not an instrument, that it's not reflecting burden of care in the Thai society. So I don't know if you are using Zarit or whatever. There are more tools for burden of care. Maybe, and it's just a suggestion, maybe that's your next project, which might be very, very valuable if you come up with a new tool to assess burden of care. It's not, and it is not specific to Thailand because you have Buddhists, basically Buddhists, in other countries. So you have at least a potential contribution to other societies as well. Maybe the tool itself is not so culturally appropriate in Thailand. Maybe, I don't know. I'm not an expert on burden of care in Thailand, but it sounds like that. If they are not reporting, and I showed you that they are not reporting, you are talking about almost 3 years that they are giving care, 7 days, 7 hours a day, and still talking about moderate burden of care. Well, it might be, but it sounds familiar when you are talking. That's the first thing that I would do. Check the instrument if it's
Thank you so much because I look forward to develop some tool because when we use the solid, it's not fit to our population, we think. And also it's like the same question from the Ajahn Kanjana that had talked about the instrument development. So right now we try to review and try to search for the instrument that may be fit to our context. Thank you so much.
I think you should run out of the room now because I have another suggestion. So go now. No. Now the second thing that might be done is not to develop a new scale, but to adjust the scale, to adjust the pointings, meaning that if the scale is running from 0 to 48 Zarit, and 0 is very low burden, maybe in the Thai culture, 4 points or 5 points means a lot of burden, maybe. It's not according to other societies, it's specific. Is running, is it okay? It's not specific, it's not according to other societies. However, it might be very usable in the Thai society and maybe when investigating the Buddhist community, which is a very, very large one. You might have a huge potential first for publication and first for fundraising. If you spot an issue with a tool and you can come up with a new tool or at least to perfect a tool in order to be culturally sensitive, you are sitting on a gold mine. You will be able to publish, you will be able to raise money, and you will be able to have more students. Don't fall on him, just cap on cap.
I would like to support these ideas because I did the data collection at the Chiang Mai Neurological Hospital last couple of years. And I feel like, okay, the Western people look at the caregiver burden different from the Asian people.
Yeah.
For example, the Thai caregiver, they may feel, oh, it's not burden for them. It
Yeah.
is moral responsibility
Yeah.
that they need to take care of the parents as well. I think that's a good idea to, I try to find out the measurements, the instrument that measure the caregiver burden specific in the Asian culture and in the Thai culture.
Yeah.
But I can. I think that's a good idea to, like, if we have the instrument that fit with our culture. And also another idea is to do the mixed method study,
Yeah.
to do the qualitative study. Qualitative is valuable in terms of find the hidden source of the caregiver burdens in our culture. So thank you so much.
Totally right. And I will add a bit more. Now, if it's for a long, we have to go? No. Yes, we do. Okay. No. Just a minute. If you have enough time, and I'm not, and usually the ones who are in the academia, and especially the ones in the first stages, they don't have enough time. They have to publish. Okay. However, later on, start with qualitative. Understand, especially the domains of burden. Try to come up later on with a quantitative tool, because on quantitative tool, you can screen the population. On qualitative, it is one by one. It's not screening, it is interviewing. And that might give a new tool coming.
I really enjoy your section a lot.
Thank you. Okay. Thank you. Cup and cup. You have to go now? Yeah. Well, I have time. I can talk and talk. But yeah. Okay. So thank you so much. It was an excellent experience teaching other students as well. And please feel free to send an email, scan it. If you are writing a paper, cite me. I'm doing good job. And I will cite you as well. Cup and cup.